Thanks very much. This is me. I'm an orthopaedic surgeon. I was also one of the first orthopaedic surgeons to get a diploma in sports medicine when I went to the London Hospital course in 1986-87. Sadly, most of my contemporaries seem to have retired. But anyway, I'm still going. I'm going to talk to you about controversies and pitfalls which may be of interest to you in the upper limb with regard to sports. And we're going to cover some instability, some tendon issues, something about the AC joint, and then something about the elbow as well. This is the Stanmore triangle. We all think of shoulder instability when we go to medical school as being, you go into a rugby tackle, some big fat 20-stone bloke wrenches your shoulder out and that's your dislocation. But there's a lot more to it than that, particularly in sport and recreational medicine. And laxity and muscle patterning are two very important factors. And the principle of this Stanmore triangle is that anybody who dislocates their shoulder has got an element of all of these factors to do with their dislocation. So, anterior dislocation, the more observant of you would have noticed that there's a bony injury there, and more of that later. How do you manage it pitch side? Try a very gentle early reduction, and the best way of doing that is to get somebody prone over a couch and just gently pull on the arm. Don't employ classic manipulation methods, but please do document whether they have any regimental badge injury and whether they can actively use deltoid. Axillary nerves commonly injured in shoulder dislocations, and what you don't want to do is that. And I get medical legal cases where people have had quite reasonable dislocations which should be nicely managed, but they've forgotten to x-ray and have managed to reduce the shaft into the glenoid, which, as you can see, is probably not a good idea. Investigations, then plain film, obviously. CT scan if you have any bone loss. Now, in the more chronic situation where people come to see you, I often get referrals saying, this chap needs an MRI arthrogram. No, he doesn't. There's been a couple of studies which have shown it doesn't actually alter decision making when you come to the surgery, and they're not that sensitive or specific. And in any case, if you're going to have somebody who's got an unstable shoulder, they're going to need an operation, and your EOA and arthroscopy will give a much better idea of what's going on. Something like 97% of young people who dislocate the shoulders will have one of these injuries. Bankart wasn't the first person to describe this injury. It was Perthes, he with the hip frame. But what you do is strip the capsule and labrum off the front of the glenoid. And it doesn't heal back where it belongs. So you continue to get that mechanical injury, that mechanical defect, and recurrent dislocation is a big complication. Still a lot of misunderstanding about how long you should immobilize these people after a dislocation. The answer is you can stick them in a sling for 1, 3, 6 weeks. It makes no difference to recurrence rates. So you can use a sling for comfort only, please. Does physiotherapy make a difference in the acute traumatic situation? Answer, not really. And this is the one paper that I found that actually showed it made some difference. But unless you've got somebody who's got a significant muscle patterning or hypermobility component, sending somebody off to physiotherapy following a first-time dislocation, particularly in a sports person, is not helpful. The risk of recurrence is largely down to somebody's age, in fact. The risk of recurrence in that paper, historically 1950, shows exactly the same that many other papers have reproduced over the following decades. And in fact, the younger you are, the more likely you are to go on to have recurrent dislocations. And if you're under 25, you've probably got a 90% chance of going on to get further dislocations if you continue to indulge in sport. And in a series from Canada, 100% of teenagers went on to get further dislocations. So how do we manage these? That Bankart lesion I showed you is typical, as I said. And this Japanese researcher called Ito noticed that when he was operating on these patients, if he put the patients in internal rotation, rather than bring the Bankart injury back to the glenoid, it actually pulled it off. So sticking somebody in a sling in internal rotation is counterproductive. You're actually moving the bit that's supposed to be healing away from its normal position. So he moved the arm into external rotation, and lo and behold, the Bankart lesion was repaired back to the glenoid, or moved back to the glenoid. So he thought, right, well, if you stick people in an external rotation brace, that will work wonderfully. And so he published some figures looking at people who stayed in the external rotation brace for 3 weeks, and miraculously, hugely improved the risk of going on to get recurrent dislocation. Unfortunately, when Europeans and North Americans tried to reproduce these figures, they simply didn't match. And it seems that if you're Japanese, you do as you're told. And if somebody says you walk around in a sling like this for 3 weeks and wear it at night, that's exactly what you do. But your average European or North American will say, put it in the bin, stop moving their arm around. It doesn't work. Might be worth trying if you really, really don't want to have surgery, but otherwise it doesn't work that well. So if you're a young sportsman, you dislocate your shoulder, we know you've got a very high recurrence rate, why not operate on early? And there's been lots of papers which have shown you can turn around the recurrence rate from 95% down to 5 to 10%. And there's papers upon papers and papers which have demonstrated that. But it really doesn't seem to have gone into common practice in the NHS, probably because of a resources problem rather than any logic. But if you're managing a young, particularly somebody in the contact sports area, who dislocates their shoulder for the first time and they want to carry on playing, find yourself a local surgeon who's competent at doing an arthroscopic repair. A bit more difficult if they've got a big bony defect. They probably need either that fixing or an arthroscopic lattice. But this is fairly simple, commonplace surgery now. It's got good results, plenty of research to support early repair for first-time dislocators with contact sports. Funnily enough, or strangely enough, this doesn't seem to work with teenagers. And there are alarmingly high recurrence rates if you operate on the sort of 14 to 16-year-old lad who might be quite a good rugby player. And there's often pressure to get back to sport early. He wants to join the academy, he wants to go on a school tour, do these arthroscopic repairs, and the recurrence rate is very high. And Len Funk, who's got a very good reputation amongst shoulder surgeons, reported recurrence rates of 70% in this age group. So that's something which is ripe for further research, and we don't understand quite why this age group should be different. And we're reluctant to consider bone transfer surgery, which we know has a much less risk of going to recurrence because of the risk of osteoarthritis long term, which we simply don't know about as yet. The sort of thing we should be looking for, and this is a lovely 3D CT scan, is this bony bank art here. So this represents the bone which had been knocked off the front of the socket at the time of dislocation. That's a big no-no in terms of arthroscopic repair. If that fragment's big enough, you can actually screw that back into place with surgery, and that heals very nicely, and they don't go on to get further dislocations. On the opposite side, on the humeral head side, this is the defect that you get in the back of the humeral head associated with the glenoid, and you can get a very nasty, large impaction fracture there, which again predisposes you to go on to get further dislocations. Now, this score was named before the onset of a certain organisation in the Middle East. Whilst the French thought they had a very good correlation with recurrence rates, it's not been shown by other authors, but it is a good in terms of decision-making and counselling patients as to whether they should go on to have certainly arthroscopic surgery for their dislocations, and looking at various risk factors, two of which you'll notice are competitive sports and contact sports, and age of dislocation under 20. Now, I realise that my remit was overuse injuries, and acute dislocations perhaps doesn't come under that, but this certainly does. And this is something which you see quite commonly in contact sports players like rugby players, where they, particularly in rugby league up here, where they do a lot of falling over in tackles, and they land with the ball in their arm like that. And the glenoid, the humeral head gets pushed backwards out of the glenoid. Not so much that they dislocate, but you get these sort of chronic attritional lesions. And sometimes what happens is they tear the posterior labrum enough that you get a bit of leaking of synovial fluid in there with use. You get a flat valve effect. It closes over, a bit more fluid pushed in, and then you end up getting a cyst forming at the back of the glenoid. And this can form quite a large ganglion, which is often loculated and can impinge upon the suprascapular nerve, and so you get wasting and weakness of infraspinatus. And this is the sort of thing you'd see on an MRI scan, where you get these big loculated cysts pressing on the nerve. And it's quite dramatic, actually, the effect that this can have on what normally be a very well-muscled rugby league player with this incredibly wasted and weak infraspinatus. Surgery for this is very simple, actually. You get a probe, you find the hole, and then you push something a bit more aggressive down, and you get leaking out of this thick ganglion fluid. It's very satisfying surgery to see this stuff pouring out, and then the patients get better. Next component of shoulder instability we're going to discuss is laxity or hypermobility. So what is hypermobility? Well, there's a spectrum, obviously, and the classic score we use is the BASEM score, South African rheumatologist, but it doesn't include a score for shoulders, and hypermobility is not on a single gene. They're fairly close together, but you can have shoulder hypermobility without having hypermobility elsewhere, and vice versa. It's very useful to be hypermobile in sport. If you're a gymnast, I don't think you could be a butterfly swimmer if you didn't have a degree of hypermobility. And certainly overhead throwers and dancers also tend to be hypermobile. But you also get it in contact sports players like rugby players. And what are the sort of things we look for? Well, the first is the sulcus sign. And you can see there's a picture here of the one on your right is the patient with the arm at rest. And then slight traction longitudinally on the arm produces that enormous sulcus or defect underneath the acromion there, where we've subluxed the humeral head inferiorly. As well as going downwards, it can go backwards and forwards, and the picture there is of Angus Wallace's gentle hands on a patient called Kevin. And Kevin was standing innocently over an unconscious man outside a nightclub when police officers jumped on him and dislocated his shoulder, and he wanted to sue the police. But as you can see, even with gentle AP glide, Angus was able to sublux this guy's humeral head way out of his glenoid, and Kevin was dramatically hypermobile in his shoulders, so he couldn't sue the police. How do we manage this? Well, it's physiotherapy really, and then some more physiotherapy, and if that doesn't work, send off for some expert physiotherapy. If that fails, we might get an MRI arthrogram in that situation, but these patients often have a normal-looking MRI scan, apart from, if you have a very experienced musculoskeletal radiologist, he might report to you that they have a capacious capsule, which is lovely alliteration. But in these people, we're looking for a fairly minor injury, because they are on a knife edge. So it doesn't take much of an injury in the labrum to tip them over from laxity to instability. So expert physiotherapy, and we look not just at the shoulder. This is a rehab program which involves core control, scapular control, and then going on to look at the shoulder. And that's very important. It drives me mad when people, I refer them for core stability for this, and they come back and say, what have you done? Oh, the spheres, give me some exercises for the shoulder. It's not good enough. It won't work. Lots of operations obviously been described for this, because surgeons love operating. Trouble is with these people, you can get good early results, but in the long term, it's not good enough. They thought this was a solution when it first came out, thermal capsular shrinkage. Those of you who stayed in the hotel this morning, a far right tray with all the bacon, it started off that long and it shrinks to that long, and it's the same principle. We're heating the collagen so it shrinks. And you could actually see it happening before you. You do the sort of painting like this with a little probe, and you can see those white stripes, and you can see the joint getting tighter and tighter and tighter. And one of my patients said to me, it was like having his shoelaces tied up. All of a sudden, the joint felt stable. Trouble is, it doesn't last that long. It, like everything else with these people, they just gradually stretch out again. And although there was initial enthusiasm, people started publishing results after a year or two to say, actually, these people do stretch out after all. Now, this is a very interesting group of people. And there's some research going on in the UK and Australia looking at MRI imaging of people with unstable shoulders. And they're not normal. The brain patterns are completely different when you have an unstable shoulder when it comes to how you control your shoulders. But what we're hoping is that if you can give these people a window of time where you can do the rehabilitation properly, because it's often very difficult for these people to even start their rehabilitation, their control is so poor, that you can actually give them a chance to reset those firing patterns. inevitably, as I said, the capsule resumes its previous capacity. And what we don't want to do is very aggressive surgery with these people, because I used to do a clinic up in Leeds with a professor of rheumatology, since retired, who had a specialist interest in this, and he used to bring me patients who'd had bone block procedures in the past, and they have arthritis and an unstable shoulder. And that's not a good combination, believe you me. The thing about these people is they'll be back. The other component, muscle patterning, this is even more fascinating. Involuntary positional instability, there's lots of names been described, but essentially these are people who cannot control the ball in the socket. So their muscle firing is even more screwed up than the previous lot. This is an example of what we get. This is the pseudo-winging. There's nothing wrong with the muscles controlling the scapula or the nerve supply. And if you look at the next picture, you see as she lifts her arm up towards 90 degrees, her humeral head is actually subluxed backwards out of the socket there. And then there's other people who do this voluntarily. So this guy is actually, by abnormally contracting the various muscles, slipping his shoulder out of joint. And some of these people find real difficulty controlling their shoulders. I mean, this is this unfortunate woman who kept coming up to A&E. They'd stick her in a brace, her shoulder would be in, she'd relax, and the thing would fall out of joint again. And this is a very complex problem to deal with. They are most difficult to manage. There's often a lot of psychological overlay. We used to have a 14-year-old girl, every time a boyfriend dumped her or exams were coming up or she had a row with her father, she'd come up to A&E with her shoulder out of joint, demand it be put back in place. Of course, as soon as she gets back to the ward, it falls out again. It really is very difficult. If you have this category of patient, the Royal National Orthopaedic Hospital in Stanmore has got a residential facility with all sorts of multidisciplinary teams to help care for this category of patient. More specifically, sports now, throwing injuries. And this is a picture of Steve Backley. How many people here could put their arm in that position? There'd be a lot of ripping and tearing if I tried to do that. And often these people present with pain. They present with pain and impingement signs. But it's not impingement that their issue, it's instability. And this has been worked out over in the States because of the enormous amount of money that goes into baseball. So my travelling fellowship, I went over to Los Angeles and stayed in the Curl and Job Clinic, and they had this most fantastic setup. Their room about the size of this auditorium, which was just devoted to looking at EMGs and very high-speed video of baseball pitches. They even had a proper mound there, and these guys would come and throw into a net, and they'd be videoed and have EMG studies, so they're working out exactly what fires and how to correct any abnormal firing patterns with these patients. But they get impingement, and it's because of instability. It's occult anterior instability. And the reason they get the pain was worked out in the early 2000s and published consecutively by French researcher Gilles Walsh and Chris Jobe, who's the son of Frank Jobe, who described the Jobe relocation test. And I went to visit them both on my fellowship. So these people have occult instability. And what happens when you're in that cocking position is that because the front of the shoulders lax, you actually get the undersurface of supraspinatus pushing off the posterior superior labrum. That's what internal impingement is. And Frank Jobe's relocation test is not a relocation test, it's actually a test for internal impingement. That's what it's actually assessing. And this is the sort of thing you see arthroscopically. This is the patient who's got a superior labral tear at the back there, with a defect there where the internal impingement has actually levered off the posterior superior labrum. And the treatment for this is not just to repair this area, but manage their anterior instability as well. So you need to tighten the whole shoulder up. That's if physiotherapy fails, of course. Rotator cuff. Sure, I don't need to teach this audience much about rotator cuff symptoms. But the etiology of rotator cuff tears, I think is still misunderstood by too many people. The original concept of rotator cuff tears with Charles Neer was that impingement led to damage to the tendon, which led to a tear. And that was what he thought the vast majority of rotator cuff tears were attributable to. And then came the other theory, looking at degenerative tendinopathy. And in fact, we now know that Uthoff was probably right, and that only about 5% of rotator cuff tears are from superior erosion. So this concept that Biliani produced to support Charles Neer's context, that it was impingement from above that caused rotator cuff tears, has subsequently been debunked. So it doesn't matter what shape your acromion is, it's got nothing to do whether you've got to have a rotator cuff tear or not. And this paper was one of those that went some way towards looking at that. You don't get changes in the bursa with an undersurface tear until you get full thickness tears within the of the rotator cuff. So it's got nothing to do with the shape of the acromion. It's all to do with age. So once you go about 40, you're past it. Your tendons start degenerating. Sorry. Corticosteroids in tendons, bad news. Bad news in vivo, bad news in vitro. But we all still use them. Patients demand them sometimes, don't they? What about rotator cuff tears in athletes? They can happen with these overhead athletes, as I mentioned, particularly with throwers. And in contact sports, you can get them with weight training and rugby players, particularly associated with the dislocations. The trouble is with these guys is they're often so keen to get back to their sport that they ignore the rotator cuff tear and then it just grows. And I've seen some awfully large rotator cuff tears in people who've ignored symptoms and ignored the signs. And by the way, if you get pain after a bench press, look for an unstable shoulder. Do rotator cuff repairs work in athletes? They certainly do. They get back to their sport. And it's great fun. Most of the rotator cuff repairs in this country are done arthroscopically now. We've got lots of new kit. You can do a nice simple rotator cuff repair in 20, 30 minutes once you've passed the learning curve. But there is an enormous failure rate. There was a recent large UK study out of Oxford which showed 40% on ultrasound scan had recurrent tears at 6 months. Now, you could argue that ultrasound scan isn't the best means of investigating these people at that stage, but there's lots of other studies using arthrograms have shown similar problems. But the pace doesn't seem to matter to the patients, actually. Certainly for the first 2 years, the patient-recorded outcome measures remain pretty much the same. Then they start tailing off, and if you're in clinical practice for long enough, you'll see patients coming back with larger tears and getting recurrent symptoms. How to improve this? Well, I predict that any of the younger members of the audience, if you have a rotator cuff tear in your later life, that you'll probably have a patch, and this is a patch that I helped to design, which one paper has shown can reduce that recurrence rate from 40 down to 5%, which is worth thinking about. The acromioclavicular joint, again, not the acute rupture that you can see there, but this sort of thing. Anyone know what that is? Osteolysis, yes. Atraumatic osteolysis of lateral endoclavicle. A bit of a mouthful. It's been known about for a long time, but the number of patients who come up to my clinic who do a lot of weight training and have never even had the AC joint examined properly is disappointing from the local MSK service. The more weights you do, the longer you've been lifting, the more likely you are to get this. And it's often gradual onset, and it just gets worse and worse and worse. And you can make the diagnosis simply on the plain film, and you can confirm the diagnosis with the guided injection. I use guided injections because I want to know where the local anaesthetic's going. Steroid gets put in, but it's not curative. They've got two options. They can either stop weight training, or they can have an arthroscopic excision lateral endoclavicle, and that's curative. Back to Steve Backley again. We're moving down the arm now, looking at the elbow. And not surprisingly, a lot of these guys get elbow pain, and most of the javelin throwers who were around when I was competing had got little scars on the inside of their elbow. And certainly in America, most of the baseball pitchers seem to run into this problem at one stage in their career or other. And this is because of the valgus stress on the elbow. And if you look at Steve's arm there, that's not a good action, really, if you're going to avoid elbow pain. Because if you look at the position of his humerus, that's below shoulder height. And he's got greater than 180 degrees abduction external rotation there. Now, the stresses that puts on a piddly little ligament called the ulnar collateral ligament on that side of the elbow are enormous. If you think he's throwing a javelin 90 metres at 90 miles an hour, it's not surprising that sometimes it doesn't like it. And what happens with these people is they get gradual medial elbow pain. And They're not aware of anything particular having injured, it's just get increasing pain. Sometimes they get a little bit of pop, but they can't throw as far, they can't throw as fast, and they get pain. Of course, in America, they get this little Leaguer's elbow thing. And the ulnar collateral ligaments there, it's only a scrappy little bit of tissue. They often don't feel a pop, but what's disappointing is that you do see very few people in this country, but often they've been treated for golfer's elbow, and somebody stuck steroid in them, which of course can attenuate the ligament even more. What they need as soon as they get that elbow pain, if you're ever managing throwers, take them out of throwing, adjust their technique, get the arm higher, and see if you can get back to throwing. If not, you can't repair that ligament, it's just stretched out and you need to reconstruct it. And if you haven't had an acute rupture, the figures for return are not great. Actually not great to return to sport. And sometimes if it's been chronic, you get osteophytes at the back of the lecron where the valgus forces have caused extra bone growth and extra pain. So the ligament reconstruction is like that. Figure of 8, trying to find the isometric points and using bone tunnels. It's pretty tricky surgery, you have to move the ulnar nerve out the way, and of course that's at risk. It doesn't like being stretched. So it's infrequently performed in the UK, but often the diagnosis is missed. I use artificial ligament, which is becoming a little more popular in the UK, rather than native tendon, because if you try and harvest palmaris longus, it's a scrappy little bit of stuff. And patients can generally get back to throwing at about 6 to 12 months. Gym work, contact sports, boxing, repetitive trauma to the elbow. Significant number of young people I see in my clinic with early osteoarthritis, from damage to the articular surface, from lifting stuff for too long and ignoring pain. They often get loose bodies, they get osteophyte formation, so they lose movement. You can do an arthroscopic debridement for these people, but once they've started this degenerative process off, it's a one-way ticket. And you see boxers with elbows like this who want to carry on fighting. It's madness.
We are running out of time.
I have finished. And we're holding the British Elbow and Shoulder Society meeting here in Harrogate next year. The general theme is on sports injuries, and you'll be very welcome to come along. Thank you.
Thank you very much, Roger. That was an amazing lecture, and home messages are great. We'll have some questions at the end.